Betty Joy, one of the clinical practice educators with Tertiary Mental Health, and I'd like to introduce to you Dr. George, and I will let him do his introduction. And thank you for spending the time with us today.
Thanks very much, Betty Jo. Let me organize myself here. You know, the last time I worked with technology, I had a chalkboard, and I thought I could handle the chalk dust, but I guess this is a little bit further than that. So everyone knows me. I've got a group of people around me in the room, and of course I have many other virtually also on this line. My name is George Wiehahn. I'm a psychiatrist. I've been working in the tertiary psychiatric services basically since it opened in 2004. And it's weird how it works with being an expert, because you can't, in the beginning of your career, say you're an expert. You have to look back to realize, oh my goodness, I guess I'm an expert. And this is so by default, looking back, I realized that for 12 years, I've been treating people with schizophrenia. 90% of the people admitted in the facility where I work have the diagnosis of schizophrenia, and many of them have treatment-refractory schizophrenia. So I guess by default, oh my goodness, I've been working with schizophrenia, and I guess I'm an expert. So what we're going to talk about today then is the DSM-5, and specifically how the DSM-5 describes schizophrenia and the so-called schizophrenia spectrum disorders differently. And so let's start there then. Now, when I made this slide, it looked much nicer than now, because now it looks like I have no interest. Of course not the case. I'm actually very interested in schizophrenia, but in my helpless, poor communication, I tried to say that no one paid me to sell you this book, or say that this is the best book in the world, or, you know, take two and phone me in the morning kind of thing. I am here because I am interested in schizophrenia, and I use the DSM as a diagnostic tool for psychiatric disorders, and specifically for schizophrenia. So for the next best part of an hour, we are going to talk about these things. Firstly, we are going to talk about the evolution of the DSM. And since this is about the DSM-5, even though I'm going to talk a little bit about the DSM-1, 2, 3, 3R, 4, 4TR, it is not an exercise in the history of the DSM. So I will glance over that a little bit. I like context. I like the fact that we can have a little bit of an understanding on how we got to where we got. Then I'm going to talk about the DSM-5 definitions and descriptions of schizophrenia disorders. Once again, this is about context, because if you understand how the DSM-5 describes psychiatric disorders in general, you may have a better understanding of how we got to the bewildering criteria and why we include and why we exclude, because it's not unique to schizophrenia, it is how the DSM-5 speaks. And then we will look at the diagnostic criteria. Of course, I will not bore you with the exact diagnostic criteria, because anyone can look that up in the book. But I'd like to sort of highlight the important aspects of that. And then I'm going to compare schizophrenia with the other psychotic disorders. One can almost say, in this chapter of the DSM-5, schizophrenia is the Latin, is the base language. And then, you know, how do we get from Latin to Italian? How do we get to Spanish? How do we get to French? You'll see my analogy when we get there. And then I'd like to, since I'm a clinician, like to try and explain why we bother differentiating between a dozen psychotic disorders, and hopefully there'll be some time for discussion as well. Here goes. Now, I don't like abbreviations, and so I just want to make sure that everyone knows what the APA stands for, what DSM stands for. And so as long as you understand that the American Psychiatric Association is the largest psychiatric association in the world. Last time I bothered looking, it had more than 40,000 members. And this is the Psychiatric Association that wrote the book called the DSM, and it stands for the Diagnostic and Statistical Manual of Mental Disorders, and it's the 5th edition. Your useless fact for the day is that all the other editions were in Roman numerals, but this one is in an Arabic number, just, and it also has the ability, since it's in electronic form, to have versions, almost like programs that's being updated. All right, so let's talk a little bit about the evolution of the DSM. The DSM started in 1952, which was approximately 3-4 years before the launch of the first psychiatric medication, and the DSM-5 was launched in May of 2013. So, needless to say, I wasn't around when the DSM-5 was published, and I had to look this up, and I had to scratch my head a little bit and try and translate this. We have psychologists in the room who can correct me if I get this wrong, but it looked like the DSM-1 described psychiatric disorders as reactions to things that happen in the environment. And so schizophrenia was described as a schizophrenic reaction in response to some stressor or something that happened, and then as that a small group of people, a small percentage of people will have this schizophrenic reaction. Then the DSM-2 came out in 1968, which was the year that both my parents, who are PhD psychologists, completed their training in clinical psychology, and my father, who is now 81, talks fondly of the DSM-2, saying that, those were the days of psychodynamic analysis, and, really what happened since then. And so the concept of psychodynamic or psychodynamic concepts is that something happens earlier in your life that has an effect on you that you hold on to subconsciously, consciously, and then when other things happen to you later on, you kind of subconsciously put two and two together, and it rules you. It compels you to behave in a certain way. Please don't take that as fact. This is the Georgian version of psychodynamic understanding. And so by 1980, politically, the American population was ready for something less hocus-pocus than that. Once again, I'm not saying psychodynamic theory is wrong. It's just politically at that point, it was time to try and sell psychiatry as a more scientific, more medical way of approaching psychiatric disorders. And so that was the empirical approach. And that was actually the beginning of criteria, and also the beginning of the 5-axis diagnosis, which, by the way, was dropped in the DSM-5. So the DSM-3R then in 1987 is where I was a medical student, and that was the first time that I was introduced to the DSM, and there was a lot of focus on biology and genetics at that stage. Another interesting useless fact is that the 1990s was declared the decade of the brain. And so it was very fashionable and very applicable at the time to talk in terms of biology and genetics. The DSM-4 and the DSM-4-TR, which stands for text references, no real changes actually happened there. And if you look at it, in the last 33 years, from the DSM-3 to the DSM-5, business was basically done in approximately the same way. And so the DSM-5 came out, as I said, in May of 2013, and we are going to focus on that. So firstly, the DSM-5 talks about key features that define psychotic disorders, and I think it's important that we focus on this. So the DSM-5 says that there are 5 domains that where a person can have psychopathology, and if you understand what to look for in those domains, then you can see psychotic features. And so those domains are, as listed here, delusions, hallucinations, disorganized thinking, and unlike what the general population thinks, psychiatrists cannot read minds, so it's actually disorganized speech, if you think about it, and then abnormal motor behavior and negative symptoms. So let's look at those things a little bit more in depth, because if you understand the domains and you understand the key features, you will later understand how we can build the diagnoses out of these building blocks. So delusions. This is probably revision for most of you, but let's just make sure that we understand what we're talking about and that we talk about the same thing. So the one definition of a delusion, at least the APA's definition of a delusion, is that it's fixed beliefs that are not amenable to change in light of conflicting evidence. Let's take a bizarre example. I may believe that I'm from Mars, and then someone shows me my birth certificate. So I look at the birth certificate. That clearly shows that not only am I from planet Earth, but I was born in a city in Holland. And then I look at it and I say, well, this is forged. I do not accept this. I'm telling you, I'm from Mars. So that is the conflicting evidence. And then, of course, the people around me who all have similar birth certificates look at my birth certificate, they look at their birth certificates, and they think, this George, he's delusional, because we all have similar birth certificates, and it doesn't make sense what he claims. And so that is the essence of having fixed beliefs that are not amenable to change in light of conflicting evidence. Now, delusions may have various themes, and I've listed a few of those. Persecutory themes will then be that what you believe and what you tenaciously hold on to and don't want to give up is that people are out to get you. Or referential, which is quite interesting, something that happens in your environment that is really coincidental somehow has very specific meaning to you. I regularly, unfortunately, see this where someone will see something on the television and say, you know, what happened there is because I did this morning. And that referential connection is a delusion of reference. So we can go on. Somatic, in other words, certain bodily experiences or certain body shapes or something that you have on you that you then have a fixed belief about. Religious delusions are self-explanatory. It's important that you understand that delusions are best assessed by your peers. So let's take an example. If you have a Christian religious delusion, it's better to get a bunch of Christians to come tell you if this person is delusional or not. So it's very important that when you talk about delusions, that you talk about peers assessing that. I always say your peers will declare you psychotic. And transculturally, things look crazy pretty quickly. So we tend to overdiagnose psychosis or delusions transculturally, and we tend to underdiagnose mood disorders transculturally because we don't speak the emotional language well. That's another talk. Grandiose delusions, I think, are self-explanatory, and bizarre delusions, I guess my Mars example was pretty bizarre. So hallucinations, perception-like experiences. What we mean with perception-like experiences is that we have 5 senses and we think we experience something through one of these senses, but actually it wasn't there. And so it may occur in any sensory modality, but usually by far in the psychotic disorders, it is usually auditory. And so once again, it may be another talk to talk about what to look for if people start smelling funny things or seeing funny things or feeling things in their skin. That's much less likely to be a primary psychotic disorder, which is a different talk. It's important to note that it occurs in the context of a clear sensorium. So if you're delirious or half asleep or falling asleep, hallucinations in that context is usually or often associated with other disorders or other illnesses. For instance, people who have hallucinations while they fall asleep may have another condition like narcolepsy. And remember that hallucinations may be considered a normal part of religious experience or cultural experience. So once again, be very clear that when you work in a multicultural environment, that you, and I say this with great respect, know what you're talking about when you start evaluating other cultures. Disorganized thinking. It can also be called formal thought disorder, which is not formal at all, but somehow this is the terminology. And remember, this is inferred from a person's speech. As I said previously, we do not read minds. We infer how someone organizes his or her mind by the way they talk. And here are examples. So derailment will be an example where you talk about a certain topic, but then you clearly jump, almost like a train that derails and you never get back. You can derail again and again and again, which can be seen as loose associations, or you can just completely take a wild turn off and go in a completely different direction, which can be called tangentiality. Incoherence, in other words, stitching your words together in a way that it just doesn't make sense, which is often called word salad. And then thought blocking or mutism can also be seen as disorganized thinking, though a word of caution, that can also be an example of catatonic behavior, which we will talk about a little bit later. So abnormal motor behavior is then the fourth example, or the fourth domain of psychosis. So we just have to talk a little bit about what volitional means. So to do something volitionally is to do something by choice. There's a mental process present in doing something. So if I choose to pick up this book, this was a volitional movement because I thought about it and I wanted to do that. So that is important to understand that if you talk about volitional or goal-directed behavior being affected, that's one of the domains of psychosis. Now, it's interesting that the APA of all associations actually use the word silliness. So please don't go out and go diagnose all silly people as psychotic. Another way of talking about it is to talk about a silly affect. In other words, someone has these weird thoughts and they express their weird thoughts, their disorganized psychotic thoughts, in bewildering states of emotion or behavior. And that's more the silliness that we're talking about, which explains unpredictable agitation because whatever drives this person's behavior is not something that makes sense to the person, to the people around that person, and that's why it's unpredictable. So unpredictable agitation, and then catatonic behavior. Let me just define catatonic behavior here. So catatonic behavior is a marked decrease in reactivity to the environment. So for whatever reason, you are so, my word, scrambled in your mind and therefore so unable to make sense about your environment that people around you think you're not responding to what they're asking or saying or when they interact with you. So examples of catatonia then include negativism. Negativism means that, once again, I think I have a thing with this book. So negativism is I hold on to this book and someone wants to take this book, but I don't understand what they want. So they can't pry the book out of my hands. I just hold on to it, and I come across as just resisting any change or resisting anything. So sitting in a chair can't get me up. Standing up can't get me to sit down. That is what we mean with negativism. Needless to say, bizarre postures is then an example, because when you're catatonic, the reason why I want to point at that light is completely bewildering to my audience, and I'm stuck here, and it makes a lot of sense to me perhaps, but no one else understands that. And that would be a bizarre posture. Stupor is being so folded into yourself, so decreased in your reactivity to your environment that you look awake and asleep at the same time, comatose with your eyes open. Purposeless activity is another example, because you can get catatonic stupor or you can get catatonic excitement. And then echoing of speech is another example. Echolalia, a little bit of Greek there. In other words, someone says something to you and for whatever reason it reverberates in your mind and it reverberates in your speech. It's important to note that catatonia is not a symptom exclusively associated with schizophrenia. And we'll talk a little bit about that later on. but people who are very depressed can grind to a halt in catatonia, or people who are demented, or people who have general medical conditions. For instance, hypothyroidism. You can have such a low metabolic rate that eventually you grind to a halt and you look catatonic. Parkinson's disease can also look as if you're catatonic because you cannot initiate a certain behavior. So the last domain is the domain of negative symptoms, and by definition that is the absence of behavior. It's important to note that psychosis, the other domains, often describes excess behavior, but negative symptoms describes the absence of behavior. So examples include diminished emotional expression. They say, I don't know exactly who they are, but they keep on popping up every time. They say that about 7% of what we communicate verbally, but the other 93% we communicate non-verbally, and that's what we mean with emotional expression. How I change my voice, how I roll my eyes, how I change my facial expression. And so negative symptoms then means that you say something, but the rest of the message isn't there. Alogia is a state where there's diminished speech output. Think about this. People with schizophrenia or people with psychosis can eventually end up having very little thoughts. And so if you don't think about a lot of things, why will you say a lot of things? Anhedonia is another rather Greek kind of word, which is the decreased ability to experience pleasure from positive stimuli. It's often that ability to experience pleasure that motivates us to do anything. And if your world is rather blah and rather gray and rather empty, why will you not just sit and not engage? And evolution is then exactly that. It's a decrease in motivated, self-initiated, purposeful activities. So people with psychosis can literally sit and not be bored. And it has to do with the domain of negative symptoms. Just note that negative symptoms probably are mostly associated with schizophrenia as an example of psychotic disorders. So now that we know that, let's look a little bit about at the diagnostic criteria, and the Georgian version about that is how do you build a DSM-5 diagnosis? So here goes. Basically, you have criteria. So you have A criteria, B criteria, C criteria. It's like the fingers of your hand. A criteria, B, C, D. And so the A criteria are the criteria that describe the syndrome or the disorder you have. The description of the required symptoms and signs, also known as the domain of psychopathology. So the stuff we see. Those are the A criteria. The B criteria relates to the fact that the A criteria must lead to a significant impact in your function. I remember once in court I was asked by a judge, why, Dr. Wiehahn, do you think that this person's beliefs constitute schizophrenia? Because I have friends who have very interesting ideas about life and have rather weird statements about that. And my answer was, Your Honor, your friends go to work from Mondays to Fridays, and they kind of need a third beer in a bar to kind of say these things, and all in all, they're relatively functional. So it's important to understand that the symptoms on its own, without function loss, just does not constitute the diagnosis, and that's why it's built in, the B criteria. The C criteria often include expected timelines. Remember what DSM stands for, right? Diagnostic and Statistical Manual. So the research, the statistical research on how many people get it in the population, but also, if you make your timeline 1 month versus 2 months versus 2 weeks, you can make timelines such that 50% of the population has an illness. So you have to find that point where the illness still, or the disorder is still set aside and shows pathology. So that's why we have timelines. The D criteria are exclusion criteria, because often there are disorders that are somewhat similar to other disorders, and we have to make sure that we can describe why this disorder is not that disorder, so exclusion criteria. And the E criteria will then be excluding medical conditions or substances which may mimic aspects of the disorder. Just to make it as confusing as possible, sometimes you need more fingers than on one hand, so there can be F criteria, or now I forget my alphabet, more criteria, because sometimes there's overlap with very specific disorders that you have to exclude. So I think if you understand this, and you understand the 5 domains of psychosis, we actually have a box of Lego, and we need to build a few things here. So to summarize, the A criteria are the criteria that describes the illness. The B criteria highlights the fact that you are not functional. The C criteria highlights timelines. Let me give an example of a timeline. Who in this audience has had a blue Sunday afternoon? Well, everyone put up their hands, and so do I. And so if you make the timeline for major depressive disorder a Sunday afternoon, then 98.5% of the population has major depressive disorder, and the other 1.2% lie. So that's why it's important that we have timeline. And then the D criteria, the exclusion criteria, the E criteria, the general medical conditions. I had a prof once tell me that for every crooked thought, there is a crooked molecule. But that is useless to us because we don't understand molecules well enough. And so at this point, our E criteria is, as our years grow into decades, we have more and more examples of medical conditions that explain the psychiatric syndrome. In an ideal world, hopefully 100 years from now, we don't need the criteria. We just have general medical conditions. All right, here goes. So here are the diagnostic criteria of schizophrenia, and if anyone hoped to have me list them, well, I have bad news for you. I am not listing them because I'm trying to teach you how we build the diagnosis. So the A criteria are 2 or more of the 5 domains of psychosis. Remember the delusions, the hallucinations, the disorganized speech, the volitional behavior, and the negative symptoms. So you need at least 2 of those 5 domains. Then you have to display those 5 domains to the extent that it affects your functioning in your occupation, interpersonally, as well as socially. And the C criteria are the timelines. And for schizophrenia, which is these statistical research done over many, many decades, you have to have symptoms for at least 6 months, and for at least 1 consecutive month make the criteria of 2 of those 5 domains. Then you make the timelines. So the D criteria, now we start ruling out. So we want to rule out mood disorders, because in the depth of your depression, you can lose contact with reality. In the peak of your mania, you can lose contact with reality. And we want to rule that out, that we are not diagnosing someone who's severely depressed with schizophrenia. That's why we have the exclusion criteria. The E criteria then rule out substances and other medical conditions. If you're high or if you are withdrawing from crystal meth, you can look pretty crazy. And so it's better to make sure that you know if there are substances involved, and medical conditions as an example as well. People, for instance, that have Cushing syndrome, people that have hyperthyroidism can lose contact with reality. Now, the reason why there's an F criteria, remember I warned you, there's always an exception, is because autism spectrum disorders look a lot like schizophrenia. And so the APA just wants to make sure that if you diagnose someone with autism and you want to diagnose this person with schizophrenia, you'd better not hinge both those diagnoses on how the person speaks. Right? So people with autism should please also have lots of delusions and hallucinations. Otherwise, don't add schizophrenia, just stick to the autism, and that's why it's specific. Right. So now that we know how to diagnose schizophrenia using the building blocks of the DSM-5, let's compare them to the other psychotic disorders in this chapter. Here they are. a long list. And now you can see why we talk about the schizophrenia spectrum disorders and other psychotic disorders. So delusional disorder. If I say delusional disorder, I hope you can say, in other words, the domain of delusions, only that domain. And if there are other symptoms in the other domains, they're really minor. And that's why we can't call it schizophrenia, because schizophrenia needs two domains, one domain. And then the other criteria are very similar. If you look at brief psychotic disorder, not enough domains, and the timeline is too short. That's why it's called brief psychotic disorder. This, by the way, is where postpartum psychosis now goes. In the previous DSM, it was under psychotic disorder not otherwise specified, which was really a garbage can. But now it is a brief psychotic disorder because it only makes one domain and it doesn't make the timeline. Schizophreniform disorder means you make two domains, but you don't make the timelines yet. So perhaps for a month you have the psychotic symptoms, but you don't have other symptoms for 6 months. Schizoaffective disorder is that gray area. Remember, if you go to the C criteria of schizophrenia, let's see how quickly I can get back there. The D criteria, it's good that I went back, to rule out mood disorders. Well, you can rule and you can rule, but sometimes you just can't rule the mood disorder out the door completely. And so there must be recognition that sometimes a person has both a mood disorder as well as a schizophreniform disorder. And so you may make the two domains. You may make timelines. But in schizoaffective disorder, there's a clear mood disorder as well, but the psychotic component is not just linked to the mood component. So you may have depressive episodes with psychosis in it, but then at other times the mood symptoms are really well controlled, but the psychosis is still present. And that's how you get your schizoaffective disorder. Substance or medication-induced psychotic disorder is self-explanatory. So you can make the timelines and you can make the domains, but if it's clear that it is due to a substance or due to a medication that you use, a good example of a medication may be prednisone, a steroid that can affect your mood as well as your thinking. And then a psychotic disorder due to another medical condition. And I've mentioned hyperthyroidism before. It's interesting that, I guess I can mention brain tumor here, but the problem is that's other problem because there may be many other neurological symptoms at that point. And so I'd rather try and mention more systemic illnesses that seem to be a little bit more hidden or even insidious. It's interesting that the DSM-5 added schizotypal personality disorder in this chapter. So think about this for a moment. You may make the domain, or at least one of them, maybe two of them. You may make the timelines. But all the other disorders are disorders where you are drawn out of character. George is like this, but when George is crazy, he's like that. But what if it is George's character that he has the domain? Then it is a personality disorder. And so that's why schizotypal personality disorder goes under personality disorders, but it's also mentioned in this chapter because it has to do with the domain. It's interesting that also people with schizotypal personality disorder can do with antipsychotics and a treatment approach that is not too dissimilar from the treatment of other psychotic disorders. We talked about catatonia as not being exclusively part of schizophrenia, and so there's recognition that if catatonia is the domain, the motor evolutional behavior domain, then there can be a diagnosis that you have catatonia because of a medical disorder or another mental disorder, as I've mentioned before, depression or mania even, definitely dementia. Of course, at the end of the day, it doesn't matter how many baskets you create, there will always be syndromes of behavior or syndromes of psychopathology that just doesn't fit. And so here are the examples. So other specified and unspecified schizophrenia spectrum and other psychotic disorders. So they've tried really hard to not use NOS, but I think it's damn close. And so, for instance, I have a patient who only presented with auditory hallucinations. Just that. No other examples, no other domains. So are we going to call that what? Right? We can't call it delusional disorder. We can't call it brief. It's been 2 years now. We can't call it schizophreniform disorder because it doesn't make two domains. We can call it schizophrenia, no negative symptoms. We can't call it schizoaffective disorder. So what are we going to call it? So the DSM-5 suggests we call it a specified schizophrenia spectrum disorder, specifying that it's hallucination. I don't know if it's that useful, but that is their answer at avoiding the whole NOS thing. Let's talk about specifiers for a moment. Remember, most, if not all, psychiatric disorders are chronic disorders with fluctuating course. And so it is a good idea to add some specifiers so that you can describe where in the continuum of this course does this person find himself. Let's take schizophrenia, for instance. I have it here. So it can be a first episode, or it can be a recurrent episode. You can be in between episodes, right? So it can be a first episode currently in full remission, or multiple episodes currently in full remission, or multiple episodes currently in partial remission. So the specifiers are more there to try and describe where do you find yourself in the course of your chronic illness. And you can specify with catatonia. You can talk about being in an acute episode, and that's just schizophrenia. So I'm not even going to try and list the specifiers. The specifiers are relatively intuitive. I don't think anyone will hold it against you if you don't use the exact wording. But specifiers are there to describe where the person finds himself in the course of the illness. So as a doctor, I'm trained, diagnosis first. If you don't have a diagnosis, doctor, how can you treat the patient? And so the question is, why do we differentiate between all these illnesses? So I poured myself a glass of wine, and I thought about this. And I thought, well, maybe we are looking for differences, because if we can distinguish between these two illnesses, that it will actually be a different treatment approach. Or maybe if we differentiate between this and that illness, the course, how this will play out, will be different. Or maybe, as I said, the outcomes, so morbidity and mortality. So that may be reasons why it's worth looking for differences. Now, before we go to discussion, let me start then by mentioning one last thing on the differences. The DSM-5 dropped the subgroups of schizophrenia. And this may be a good example why it was not worth differentiating. So in the previous versions of the DSM, you could talk about catatonic schizophrenia, or paranoid schizophrenia, or disorganized schizophrenia, or, lo and behold, undifferentiated schizophrenia. And if you look at the ICD, you can talk about simple schizophrenia, or hebephrenic schizophrenia, right? And you differentiate. But unfortunately, at the end of the day, the treatment plan was the same. And I think the DSM-5 was wise in saying, let's trim off when differentiation actually does not have value. It's like me, If I can call myself a scale and I pick this up and I say, I think this is about 4 pounds, it's useless for me to say this is about 4.183 pounds. Let's just trim that off because it's not going to make a difference. I can't measure that accurately. And so I think that's a good example of why it's better to not over-differentiate. So we have about 20 minutes left to talk a little bit about what it is that you wanted to hear. Maybe you have specific questions, maybe you have comments, and of course, there may also be questions or comments from the other sites that connected with us. I'm slightly technologically challenged since there is no chalk dust on my table here. I don't know if someone's going to ask me a question unless you show me, Betty Jo.
Oh, well, Alan, did you receive any questions from the chat?
Yes, there are. And so people feel free to either speak up or send a question through the chat. One group asked the question, we frequently see a diagnosis of schizoaffective bipolar type. Is it primarily the mood disorder?
Yes. So schizoaffective disorder, as I've mentioned, is a disorder where there is clearly a mood component, but there's also clearly a psychotic component. If I have to quote the DSM-5, the DSM-5 says that the affective component, the mood component of the illness or of the disorder, is the major component. And that's why the DSM differentiates between schizoaffective disorder bipolar type and schizoaffective disorder depressed type. So the DSM wants us to diagnose people who have bipolar disorder with schizoaffective disorder bipolar type if they have discrete psychotic episodes between their mood episodes, but they clearly have bipolar disorder. And so I think that is how the DSM wants us to describe schizoaffective disorder bipolar type. In the tertiary psychiatric services that I work, I find it interesting that almost every second patient has the diagnosis of schizoaffective disorder. And so I would like to caution those who sort of have the legal responsibility to make diagnoses to not use schizoaffective disorder as an umbrella diagnosis, but rather, use it as a scalpel. I personally think that schizoaffective disorder as a group should be a small group. Remember, people with schizophrenia have the ability to become depressed. That doesn't immediately give them schizoaffective disorder. Alan, what else do you have?
Somebody is asking about the language of positive symptoms. Are we dropping that language?
Correct. So we are not talking about positive symptoms. In the previous DSMs and in the years gone by, we talked about positive symptoms in comparison with negative symptoms, where negative symptoms really represent the absence of behavior or diminished behavior, and positive symptoms are those domains like hallucinations, delusions, and disorganization, where there's excess behavior. And so positive symptoms, even though everyone knows what you mean, is not in the DSM-5 anymore. So it's not wrong. I think for at least the next 30 years, people will know what you're talking about if you talk about positive symptoms. If you talk about positive symptoms, I think it's more important to remember the term negative symptoms, because that is actually one of the domains and seems to be more associated with schizophrenia. So positive symptoms will probably get you to any of the diagnoses in the chapter, but negative symptoms will get you much closer to schizophrenia as a specific diagnosis. Alan?
We have another question. This, I guess, is more about scope of practice. Who can actually diagnose a mental health? Who can actually make a mental health diagnosis?
Well, anyone can make a mental health diagnosis, but for the purpose of legally making that, I know that psychologists have training in making a diagnosis that has legal value, either to an insurance carrier or to a treatment for a treatment team. And psychiatrists, I definitely often use my psychologist colleagues to put a fresh pair of eyes and see what they get. So it's usually psychiatrists, physicians, and psychologists that can make a diagnosis that will have legal value. In other words, when you claim from an insurance carrier and so on. That doesn't mean that other healthcare workers cannot understand and think about how it works to build this together. And I will definitely appreciate any healthcare worker coming up with a suggestion saying, well, George, I think that there's some in this domain. What do you think? I will be more than impressed. And so, I think it's good that we all speak the same language.
And if I could just add a bit to that, I think in terms of the provincial policy and expectation, they use the language of clinical impression. And so it's not making a full-on psychiatric diagnosis, but it's making indicating an impression in the medical record.
Yes, that's a good point. And so, let's be honest, I guess I have to confess a little bit here. If you look at diagnosing a psychiatric disorder, we are ultimately diagnosing a psychiatric syndrome. And I always call it a working diagnosis. So I may use the word diagnosis, but it remains an impression. And when new information comes, or if there's a change in the course of the illness, then the diagnosis can change. A classic example is that of postpartum psychosis. If you look at postpartum psychosis, which of course is now brief psychotic disorder, by far the majority of individuals with postpartum psychosis develop bipolar disorder later on, or already have bipolar disorder and have a postpartum psychotic episode. So that's a good example of, even the best diagnosis ultimately being an impression.
I don't have any questions off the line, but just one thought that I have is that there was a fair bit of discussion about prodromal symptoms around schizophrenia, and particularly those who were interested in early psychosis and early intervention. Do you want to make any comments where the thinking is going with that?
Yes, so prodromal symptoms are not really in the DSM. Previous examples of the DSM, and I'm sure this one as well, but it's near the end and I don't have a good attention span, so I rarely get to near the end of any book. They talk about research criteria for either new diagnoses or changes in thinking about current diagnoses. And so prodromal symptoms always remained a focus of research. Because imagine that we can predict more accurately who will get such a pervasive, such a severe mental illness as schizophrenia. And so those prodromal symptoms is one way of looking at it. I realized that there was something that I always wanted to say, and I didn't, and that is I didn't pick the background of my slides because I liked it. Well, actually, I do like it. But I was struck by the plant, and it has to do with arborization. So one of the biological theories on the development of schizophrenia is that when a baby is born, a baby is sort of born with a blueprint of a brain. And depending on the genetic background of this baby and the stimulation that this baby gets, the brain grows these branches and connections called arborization. But approximately by age 6, there seems to be a first pruning. And pruning literally means that somehow, genetically and environmentally, the baby's brain says, well, it looks like it's going to be English and not French and whatever. All right? So let's prune the French a little bit back because we're going to twist our lips in an English kind of way. I'm making this up slightly to try and explain to you how this works, but that's pruning, the first pruning. And the second very big pruning, obviously, that happens is in adolescence, where that character traits come up. It's like you cut off the fluff, shall I say, and the real person underneath. That combination of your genetics and your environmental stimuli brings out who you are. And it's that second pruning that is often associated with the onset of schizophrenia. And it's during that pruning that you get the prodromal symptoms. Now, if you go back further and further, some of those prodromal symptoms are literally excessive clinginess. Now, I dare any parent in this room to give their 6-year-old, 5-year-old child risperidone because the child is seemingly excessively clingy. And so that is our problem with prodromal symptoms. If you look at them, anxiety, depression, ruminations, a drop in your school marks, right? Fall in love and your school marks drop. The risperidone is not going to help with that. And so that is our problem with prodromal symptoms. They are not specific enough, and since the DSM is trying to demonstrate its scientific basis, it does not add prodromal symptoms in the diagnosis. So that's the longest possible answer I can give for prodromal symptoms.
Well, very good. Another question. When a client describes his or her version as occasionally two-dimensional, is that inclusive of a visual hallucination?
Wow, now I'm interested. Can I get a little bit more information what that person may mean with two-dimensional? Literally that. It feels like you don't have a sense of depth. Yes. And so if you think about it, schizophrenia is a heterogenic group of disorders. As I said a while ago, I think there will be a point in the development of medicine that we won't use disorders like this anymore because there will be a medical condition describing every diagnosis. And so at this point, people who make the criteria of schizophrenia may well have 100 medical diagnoses. We just don't know what their names are. And that's why you see such a vast array of different experiences which seemingly still make a minimum of the 2 of the 5 domains. And so, I've heard people describe that they see demon faces in wood, in the furniture, right? Is that another version of this visual perceptual disturbance? Possibly. Remember when I said earlier, mostly auditory hallucinations? It doesn't preclude, it doesn't exclude visual hallucinations. So this may just be how this person experiences that. One more thing I'd like to say about specifically visual perceptual disturbance. I don't want to jump on the dissociative bandwagon too much, but people who dissociate, which is kind of an alternative state of consciousness, usually driven by anxiety, can feel like they're in a dream state, or they feel that they stand outside of themselves. And so a person may be so anxious because of their paranoia that they dissociate from anxiety. Of course, now I'm unnecessarily thickening the soup here, but I guess, once again, this is the longest possible answer for, I don't really know, but we've seen this, right? We've seen this. So many people, so many presentations of their psychosis.
And if it's new onset, get a head CT.
So this is Dr. Jennifer Klages in the room. Say, if this is the first onset, get a head CT to rule out the small but growing subgroup of criteria where there's general medical conditions.
Yeah, I don't have any more questions. Is there anybody who wants to ask one last question there? Okay.
So maybe at this point then, I look at the time. Thank you very much for everyone who took the time to listen to this. As you can see, this is not a chapter that had a huge overall from the previous chapter. So for those people who know the DSM-4, 3, lo and behold, if you know the DSM-2 and you're still working, good for you. My father is 81 and he's not working anymore. So the previous versions, at least from 1980 onwards, I think you can actually wing it and still get away, because there are not that many changes between the previous versions and the DSM-5. So stay tuned. I know that there are other presentations on other topics as well, and I know that other chapters in the DSM-5 had more overalls and changes than this chapter.
Well, thank you very much. On behalf of all participants, George, we really appreciate you taking the time and presenting today. You've just done it in a wonderful, delightful way. So thank you very much.